Let's talk about some general nursing care for patients that have cancer. First of all, patients should receive good mouth care. Many of the patients with cancer will be on chemotherapy. And stomatitis, or inflammation of the mouth, is something that commonly develops about 5 to 14 days after chemotherapy is started. There may be ulcers and bleeding and soreness. Again, the patient should rinse with saline. They should use a very soft, bristled toothbrush. They should not use drugstore mouthwashes because many of them contain alcohol, which would be very irritating to the tissues. These patients, again, should have foods that are not real hot temperature-wise, meaning really hot to the touch. They should also not have a lot of really spicy foods. Sometimes the patients will take antifungals or anesthetics, again, to help with the mouth pain. Another nursing issue is to make sure that they meet their nutrition needs, and usually patients with cancer are put on high-calorie, high-protein diets. Again, both the chemotherapy, the radiation therapy, and the cancer itself can cause nausea and vomiting or anorexia, so we want to make sure that the patient's nutritional needs are met. We want to make sure that they are in an anabolic state rather than a catabolic state. So you would have small, frequent feedings. There may be nutritional supplements that are given between meals. You want to encourage fluids, but again, it would be helpful if the fluids were given between meals rather than with meals, because then the patient would be apt to eat more. And after meals, again, good oral hygiene, and pain relief before mealtime, again, would encourage the patient to take more nutrition in. Let's talk about pain relief. With cancer, again, pain is a huge issue, and we want to make sure that our patients don't spend a lot of time in pain. They use a ladder approach with this. For mild pain, they use non-narcotic medications such as Tylenol. They also use antiemetics, antidepressants, and glucocorticoids to decrease inflammation. For moderate pain, they use weak narcotics such as codeine and other stronger non-narcotic analgesics. For severe pain, they use strong narcotics such as morphine. And again, remember when you're dealing with pain, it's better to medicate the patient more frequently. They will end up spending less time in pain. So you'll want them to take, or you will give them the pain medications on a regularly scheduled sequence or schedule, so they can take them with a preventative approach. You don't wait till they're deeply in pain. You give them the medication to prevent it. Okay. Other things, general nursing care to go with patients with cancer. Many times there are significant body image changes that go with this disease. And again, you want to encourage the patient to verbalize their feelings. You want to encourage them to participate in their care. You want to allow them to make any decisions that they can themselves. Again, it gives them a sense of control where possible. Again, the medications are antiemetics, analgesics, and antidepressants that the patient will be taking. Let's talk now about the types external radiotherapy or external radiation that is used to treat cancer. And these are the nursing responsibilities that you as the nurse will do, and you should also teach the patient. First of all, with external radiotherapy, they will put markings on the patient's skin, so each time they come in for a treatment, they will be able to line up the machine, because you want the radiation targeted to the area of cancer. Now these, while in these markings, again, if it's on the head or neck, they can be, again, they can cause a body image change because you have kind of like, arrows and boxes on your face. But patients need to know to leave those markings on. It's essential so that the radiation can be delivered where it should. You do not want the patient to use creams or lotions. The only type of cream or lotion that would be acceptable would be vitamin A and D ointment. Other creams and lotions contain things that will interfere with the external radiation. You want to check for redness and cracking because, again, the patient may develop kind of a sunburned appearance, like they've been outside too long. And, again, you want to, give care for that. They should wear cotton clothing, again, because it breathes and it's less irritating to the skin. And, again, antiemetics are used, and they're used before the patient has the external radiotherapy to prevent the development of nausea and vomiting. Let's take a look and talk a little bit about internal radiation. And with internal radiation, it can be given two ways, either with a sealed source or an unsealed source. Let's talk first about internal radiation with a sealed source. What this does is they mechanically position a source of radiation in a body cavity or into the tumor itself. So it's sealed, it's in the tumor, inserted in the body. The patient will be in a private room. There needs to be a lead container with long-handled forceps in the room in the event that the implant gets dislodged. All dressings, all bed linens are saved and kind of stockpiled in the room until the implant is removed. That prevents the accidental, the implant comes out, people don't know that, they gather up the linens, take it to the laundry, and now the people in the laundry have live radiation in their midst. So all dressings, all bed linens are saved in the room until the source is removed. Now the thing to remember, and you might say, well, oh gosh, I've got to be careful here. Well, the urine and feces are not radioactive because, again, remember, this is a sealed source. The radiation is being delivered in a very targeted area. Now, that said, you do want to take some precautionary measures. You would not stand close to or in line with the source. For example, if there was an implant put in the cervical area, you would not stand at the foot of the bed, which would be in a direct line with the implant. And again, you stand as close as you need to, and not any closer than that. So you do not need to go right up next to the patient unless there's some reason for you to do that. This patient will be on absolute bed rest. You do not want them up and walking about the room. Again, it may cause dislodgement of the radioactive source. Let's now talk about nursing care for internal radiation with an unsealed source. This is where a unsealed liquid is given orally or instilled in a body cavity, and the important thing to remember is that then it is absorbed by the body. So one of the things that is crucially important to know is the fact that all body fluids are contaminated. This is urine, feces, sweat, and the greatest danger is within the first 24 to 96 hours. Let's now talk about some of the nursing care for just internal radiation, either with a sealed or an unsealed source. The thing to remember, and the most important concept, is the fact that time and distance matter. You want to spend limited amount of time, and you want to have the greatest distance from the patient or the source of radiation that is possible and still get what you need to get done. These patients will be in a private room. There will be a sign on the door that says, "Caution, radioactive materials." Nurses will wear a dosimeter at all times. And some people think that this protects the nurse against the radiation. It doesn't protect the nurse. It monitors the amount of radiation the nurse is exposed to, so it can be measured. You want to limit visitors, and again, the nursing personnel or the healthcare workers should spend limited amount of time in the room. You spend enough time in the room to get the work done, but not any more time than that. And also in the rooms, there will be a shield that the nurse or the healthcare worker can stand behind while just talking with the patient, again, to decrease the exposure of the nurse. Staff should be rotated through the room, and no pregnant nurse should care for this patient. One of the other things important, and again, it goes back to the time spent with the patient, we want to encourage these patients to do as much of their own care as possible. So if they can give their own bath, change their own, clothes and all, we want them absolutely to do that. Let's go on and talk about leukemia. Leukemia is a frequently tested topic on the NCLEX, and the most common questions deal with bone marrow aspiration or the nursing care for patients with leukemia. The type of assessment you'll see, there'll be ulcerations of the mouth. The patient will have symptoms, and their lab will show that they are anemic. They will be fatigued. They'll have weakness and pallor. Now, you remember that leukemia is a fatal neoplastic disease that involves the blood-forming tissues of the bone marrow, spleen, and lymphatic nodes, or lymph nodes. It's abnormal. It's uncontrolled. There's destruction and proliferation of different types of blood cells. One of the things I said that it's important to know is the bone marrow aspiration. Let's talk just a minute about that because, again, it is frequently tested. You want to make sure that the patient or the parent, if it's a child, signs the informed consent. Usually the bone marrow aspiration is done at the iliac crest or the sternum. A local anesthetic is used because the procedure is painful. And then a sterile dressing will be applied to the area with pressure after the procedure is done. Now, there are different types of leukemias. There are acute leukemias that have very rapid onset and progress very quickly to a fatal outcome. There are chronic leukemias. These have a more gradual onset and a more prolonged course. Let's take a look at the nursing care you will do for patients with leukemia. We will want to monitor them for signs of bleeding, and these would be things checking for petechia, the bruising or area of ecchymosis, thrombocytopenia, again, because the blood formation of the thrombocytes and things needed for clotting will be abnormal. You want to monitor for signs of infections. This would be changes in vital signs, again, neutropenia, a white blood cell count less than 5,000, or fever and chills. You want to make sure these patients have good mouth care because that is a problem. They should be on a high-calorie, high-vitamin diet. They will be put on what we call neutropenic precautions. And let's talk for a minute about what that means. It means that the patient will be in a private room. You'll limit the number of people that go in and out of the room to limit exposure to bacteria and diseases. The patient will have their WBC count assessed or done daily. No fruit, no flowers, no potted plants in the room because, again, they may carry bacteria. The patient should clean their toothbrush with either a weak bleach solution, or if they're home, they could put it in the dishwasher. The patient, for the intake, we talked about the high-calorie, high vitamins, but they should avoid salads and raw fruit and raw vegetables, again, because of the chance of pathogens. They should avoid pepper or paprika, again, because that could cause a problem. The patient should not reuse a cup. When they drink from a cup, they should put it aside, and the next time they want to drink a water, they should get a new cup. And these patients, if they have pets, especially cats, should not be changing the litter box. They should not be out digging in the garden, again, because of the danger of pathogens. Medications used for leukemia are the chemotherapeutic agents and the antiemetics, and we talked about those in the pharmacological and parenteral therapies unit, and please do review those. They may also use chemotherapy or radiation for patients with leukemia, and they might also have a bone marrow transplant. Let's go on and talk about croup syndromes. Most children sometime during their childhood experience croup, and this can be a very frightening situation for parents if they are unprepared for it. What the child will present with is a bark-like cough, oof, oof, and it again can be very frightening to parents because they've never heard their child sound like that. The child will have dyspnea or difficulty breathing. They may have cyanosis or bluish color, and they will have inspiratory stridor, and then, this whoop-like coughing. Because remember, croup is a viral infection of the lower respiratory tract, and it can be, and many times is, a medical emergency because it narrows the airway of children and infants, and that it causes serious problems. Let's take a look at the type of implementation you'll do. Most of the time, croup can be handled at home, and you want to make sure the parents know how to handle it at home. What you do is, croup almost always happens in the middle of the night. Rarely does it happen during the day. So when the child wakes up or the parent wakes up and hears the child coughing and barking, they will take the child from the bed, they will go into the bathroom, turn on the shower high, and then sit there in the steamy shower. And over time, the child's barky cough will subside. Sometimes they decide, we got to go to the hospital, and the act of actually taking the child outside or the sudden exposure to cool air or cold air will cause the child to get better. And once the child is better, you're still in the shower and the child appears to be better, there's less inspiratory stridor, they're not dyspneic any longer, there's no cyanosis, you will have the child sleep with cool, humidified air. But one of the things you want to share with your parents is, well, how do I know I should take the child to the hospital? How will I know? Because again, you don't want to wait till the child is, cyanotic and apneic. They're no longer breathing. So the things you want to tell your parents are, if you're sitting in the steamy shower and your child does not appear to be getting better but has increasing respiratory distress, it's time to go to the hospital. Either you take the child yourself or you call 911. If the child appears hypoxic or has a decreased level of consciousness, again, it's time to go to the hospital. That would be an indication for hospitalization. Or if the child has a high temperature, 102 degrees Fahrenheit or better, the child should be hospitalized. Let's talk about what happens when the child is hospitalized. Well, when the child comes in again, maintaining a patent airway is the first and foremost implementation that the nursing staff will be doing. And if the child, appears to be doing okay and breathing okay, they will still keep a tracheostomy set at the bedside in the event that it's needed. There's nothing like needing a trach set and you have to send to central supply to get one. It will be right there at the bedside. Frequently, they will put these children in croupiette or mist tent. And again, we talked about this implementation and reduction of risk. This is where they have oxygen and humidification in a tent that is over the child's crib or bed. And the thing to remember here is that because oxygen is in use, you don't want any flames or cigarettes by it because we don't want anyone to blow up or get hurt. You also need to, because of the high humidity, to change the linen frequently and to change the clothes of the child frequently. And again, it's preferable that the child sleeps or stays in cotton clothes rather than polyester or something that doesn't breathe. So again, oxygen with humidification is provided. The child will be, you'll want to monitor the heart rate because again, a change in heart rate and a change in respiratory rate are two of your early symptoms of hypoxia. These children will be given IV fluids to maintain hydration. They may be given antipyretics because again, remember, one of the symptoms for taking a child to the hospital is the high fever. These children, you would not want to lay them flat in bed. You would want to prop them either with a pillow or put them up in an infant seat. Oh, and one other thing about the antipyretics, remember they would use Tylenol, not aspirin, because you don't use aspirin in conjunction with a viral illness because of its association with Reye syndrome. Again, check the heart rate, check the respiratory rate, because if the child is experiencing increased hypoxia, you want to know sooner rather than later so you can intervene. Let's go on and talk about myocardial infarction, or what the layperson would call a heart attack. What you need to know for the NCLEX exam is how to differentiate an MI from angina pain. You need also to know about the medications that are used. These are medications such as streptokinase, TPA, or the tissue plasmin antigen. You need to know about beta blockers, morphine sulfate, drug of choice, dysrhythmias, and anticoagulants. Let's take a look at what you'll see with a myocardial infarction. Again, the symptoms you'll see will depend on whether or not is it pain, shock, or pulmonary edema that is the dominant issue in this situation. There will be chest pain, and that chest pain often radiates to the arms, the jaw, or the neck. And the key thing about the chest pain, and this is how you differentiate an MI from angina, is this chest pain is unrelieved by rest and is unrelieved by nitroglycerin. So if someone has a history of either MIs or angina, they should stop and rest with the first sign of chest pain, and they should take their nitroglycerin as ordered. Now, if the chest pain is relieved, that means that the patient was experiencing an episode of angina. If the chest pain is unrelieved with the usual treatments that cause it to go away, this person very well could be having an MI. Other signs and symptoms you'll see, many times the patients come in either to the doctor or the emergency room and they say, I just don't feel good. I think I have indigestion. I don't think I should have eaten that pepperoni pizza. it doesn't seem to be agreeing with me. So again, some of the early signs are symptoms that can be confused with indigestion. However, often the patient is apprehensive. They may be running a low-grade fever, and they will have elevated WBCs or leukocytosis. Their erythrocyte sedimentation rate will be raised because of the inflammation, and the CK-MB bands and the LDH will be elevated. And let's talk a couple minutes about these type of tests. Again, low-grade fever may be seen. Leukocytosis can be seen. Usually it will happen within 2 days, and it usually disappears in about a week. And remember, your normal WBC is 5,000 to 10,000, so anything over 10,000 is leukocytosis. Your ESR, your erythrocyte sedimentation rate, will be elevated. This shows inflammation, and the normal rate for men is 0 to 15. The normal rate for women is 0 to 20. And remember, erythrocyte or sedimentation rate, or ESR, is the speed at which red blood cells settle out of blood, and it indicates infection. Now, some of the specific tests, your CK-MB bands, this is the enzyme that's first elevated after an MI. It appears at about 3 to 6 hours. It peaks at about 18 to 24 hours, and the elevation may last 3 days. And sometimes patients will come in, and when you check the MB bands, you'll see that it's high, and then it will start to subside, which means that the myocardial damage is not brand new, that they might have been having subclinical symptoms for the last couple of days. The LDH, again, is something that you'll look at. It appears at about 12 to 24 hours. It peaks at about 48 to 72 hours, and it may last from 6 to 12 days. Remember that the key thing that's happening with an MI is there's a localized necrotic area within the myocardium. And usually it happens because of a sudden occlusion of the blood vessels in the coronary arteries. So the heart itself has not been supplied with blood. Let's take a look at some of the implementations we'll do for a patient who has had an MI. Well, one of the key things and first things they'll do is perhaps try thrombolytic therapy. These are with medications such as streptokinase and TPA. What this will do is they're kind of like clot busters. They'll go in and lyse or dissolve the clot. And we talk about these particular medications in our pharmacological and parenteral therapies discussion and actually go through the medication. What is important for you to remember, though, is that there are contraindications to this type of therapy. And one of them is recent trauma within the last 2 months. And if someone has had CPR with someone not pounding exactly, but pressing on the chest and all, that could be considered recent trauma, so that maybe this type of treatment may be contraindicated. Okay, patient will be put on absolute bed rest, and the reason they do that is to decrease the workload of the heart. You will want to monitor vital signs very frequently. You'll want to monitor intake and output. This is one patient where you will not want to force fluids. Because again, if you force fluids, you increase the amount of fluids in circulation and you give the heart more stuff to work with. And it might inhibit its ability to work efficiently. So usually you will keep the intake to about 1,500 to 2,000 cc's per day. You would not want to force fluids or encourage fluids for these patients. There are some medications that are used. They use beta blockers. They use morphine sulfate. Now, again, let's talk just a minute about morphine sulfate. Morphine sulfate is a narcotic, very good for relief of mild to moderate pain, but with myocardial infarction, it truly is the drug of choice, not only for how it works to provide analgesia, but it reduces both preload and afterload pressures in the heart. What that means is it reduces the amount of pressure coming into the heart and reduces the peripheral resistance for the blood going against coming out of the heart. So it increases cardiac efficiency in addition to providing for analgesia. Other medications are the dysrhythmics such as quinidine, lidocaine, verapamil, and the patient may be put on anticoagulants. And again, when we talk about our pharmacological unit, we talk about the anticoagulants. In the acute setting, you will use heparin, and it will be given IV. And you need to remember that the PTT is the test that is used to find out how well the patient is doing to keep the medication within its therapeutic index. And remember, protamine sulfate is the antidote if the patient has too much heparin. Okay, other things you'll do, we talked about monitoring vital signs and intake and output. Well, we've gotten the patient through the acute phase. Now he or she has survived, and we're going to talk about teaching, so hopefully they don't come back with a recurrent MI. You'll talk with the patient, and the type of teaching that should be done is you want them to stop smoking. I know it's difficult to do, but it can in some cases be life-saving. You want the patient to reduce stress. You want them to decrease their caffeine intake. They may need to make dietary changes because when you do the blood test, you may find out that they have an elevated cholesterol level. So you might want the patient or the patient may be put on a low-fat diet. And they need regular physical activity. Now, this isn't the Boston Marathon, but it is walking or perhaps jogging, regular activity, because, again, that increases the cardiac efficiency, decreases stress, does a lot toward a healthy lifestyle, and can prevent a recurrent MI. One of the problems with an MI is it can cause rhythm disturbance, and with rhythm disturbances, what you need to know is you need to know what a normal EKG looks like. On the NCLEX, you may see a rhythm strip. That's the bad news. The good news is they will ask you things such as either to calculate the pulse rate or the rate of contraction, or they'll ask you to identify aberrant conduction through the heart. So again, you need to know how to calculate the rate according to an EKG strip. You need to know the difference between defibrillation and cardioversion, and we'll talk about that just in a minute. And you need to know about medications such as the antiarrhythmics. With rhythm disturbances, the type of signs and symptoms you will see is first of all syncope, which is fainting. And that happens because of a decrease in cardiac output. Again, the patient may become dizzy. They several times or frequently complain of chest pain. They may have palpitations where their heart sounds like it's beating outside of their chest. They may have abnormal heart sounds, such as murmurs. They may have dyspnea, difficulty breathing, and their pulse rate may be abnormal. It may be increased, it may be decreased, it may be irregular. Now remember, conduction disturbances are caused by an interruption in normal conduction, and it can occur at any time during the cardiac cycle. Let's take a look at the type of rhythm disturbances you may see. Now, sinus dysrhythmias originate in the sinoatrial node. And remember, the SA node is the pacemaker of the heart. And that's where the origination of the impulse usually starts. So the type of sinus dysrhythmia, as you can see, the first is tachycardia. This is due to sympathetic nervous system stimulation and would be a pulse rate greater than 100 beats per minute. Type of causes for tachycardia could be pain, exercise, could be caused by hypoxia, could be caused by pulmonary embolism. You'll see it with hyperthyroidism or fever. Now, bradycardia is also a rhythm disturbance from the sinus area. This would be a pulse rate less than 60 beats per minute. Again, this is caused by the parasympathetic nervous system stimulation. And the type of causes for bradycardia for this dysrhythmia could be an MI, could be due to the Valsalva maneuver. Remember, we said if you do the Valsalva maneuver, it can cause bradycardia. Vomiting can cause bradycardia. Ischemia of the SA node can cause it. Also, hypothermia. Something that's altered or too low when compared to normal, exactly what does that indicate? You need. Okay, with diagnostic tests, what you need to know, 6 to 12, that type of thing, you need to know neighborhoods. The exam isn't going to ask you,
is it 5, is it 6, or is it 7? They're going to say, is it 5, or you're going to need to know, is it 5, 15, 35. So again, know the general neighborhood or general area for normal lab values. You need to know what abnormal lab values indicate. For example, if someone's H&H or hemoglobin and hematocrit are low, what does that mean? Well, it means they're anemic. And let's just say that, they have hemodilution. I mean, what does that mean? I mean, you need to know if something is altered, either too high or too low when compared to normal, exactly what does that indicate. You need to know how to prepare people for diagnostic procedures and what type of thing goes on during the diagnostic procedure, and then how you care for the patient when they come back. Some treatments and diagnostic procedures have a lot of preparation. Some have a lot of post-op care. Again, some have none. But you need to know what it is you're going to be expected to do. You need to know how the diagnostic procedures are performed so you have an understanding of what the patient's going through so you can do the appropriate teaching. And importantly, you need to know how to prevent complications from the diagnostic procedures. Okay, let's talk about some of the diagnostic procedures. The first one we're going to talk about is the pulmonary function test. You remember that a pulmonary function test detects impaired pulmonary function and evaluates the effect of treatment. So if someone has altered respiratory function, they might have a pulmonary function test. If treatment has been established and they're looking to find out how effective it is, they might also again have a pulmonary function test to evaluate the effectiveness of the therapy. Getting someone ready for a pulmonary function test, they should not smoke, if they smoke at all, for 4 hours before the test. And if the patient is on bronchodilator medications, they may be withheld before the test is done. After the test, you want to monitor the patient for dyspnea or difficulty breathing. And what they do with the pulmonary function test is they compare them to normal. And normal pulmonary function varies from person to person according to height, weight, gender, and age. So there are differences, but they would compare them to the normal for their age group, height, weight, and gender. Another pulmonary function, again, one that you need to know, and it is frequently tested on the NCLEX, is arterial blood gases, or ABGs. You need to know how to obtain them. You need to know what normal results are. You need to know care after the procedure. You need to know what complications that you're looking for and hope to prevent. Again, remember, ABGs are measurement of tissue oxygenation, carbon dioxide removal, and acid-base balance. So let's talk about ABGs. You're getting somebody ready. What do? Well, in preparation, remember you use a heparinized syringe so the blood doesn't clot. And you need to perform the Allen test before you do the ABG. And the reason you do the Allen test is you're assessing collateral circulation before you do the test, because you don't want to do a puncture into someone that doesn't have good collateral circulation. So what you do for the Allen test is you will compress the radial and the ulnar arteries simultaneously and ask the patient to make a fist. This will cause the hand to blanch. Now, after the patient opens his fist, you will release pressure on the ulnar artery while you maintain pressure on the radial artery. And the hand will turn pink again if the ulnar artery is patent, meaning I have good circulation even though I have this one still occluded. So again, what you're doing is you're checking for collateral circulation. Essentially, you're blocking the flow, arterial flow to the hand. They make a fist. You release one of the vessels, and if the hand goes from white to pink, you know that there's enough circulation with one of the vessels there, so it's safe to go ahead and do the stick for the ABG. Again, remember the arteries on both sides of the wrist. So before you ever do an ABG, you will do the Allen test and assess for circulation. Okay, you've done the Allen test. Circulation was good. You used the heparinized syringe. You obtained the sample. After you obtain the sample, you will apply pressure for 5 minutes by the clock. If the patient is receiving anticoagulants such as heparin or Coumadin, you will apply pressure for 15 minutes by the clock after the stick is done. The specimen is put on ice with the needle occluded and sent to the lab. You will note on the slip if the patient was receiving oxygen or if it was just using room air. And after the procedure is over, you're going to be checking for swelling, discoloration, pain, numbness, and tingling. Okay, another diagnostic test that can be done for patients is a sputum analysis. They use this test to identify the cause of pulmonary infections and to identify abnormal lung cells. So we're getting the patient ready for a sputum analysis. First of all, you will encourage fluid, so they'll have some sputum there. The patient will rinse their mouth with water. They don't brush their teeth or eat or use mouthwash. You will use a sterile container to get the specimen, and usually you will have the patient collected early in the AM because we have more sputum, if you will, early in the morning. Okay, another test is a bronchoscopy. This diagnostic procedure is frequently tested, and the type of things you need to know are how to get the patient ready, what is the preparation, what's involved in the procedure, what care do you give the patient after the procedure, and what complications are you hoping to prevent. You remember the bronchoscopy allows visualization of the larynx, trachea, and main stem bronchi. You can use, or they use a bronchoscopy to get a tissue sample for biopsy. They can use it to apply a medication. They can use it to aspirate secretions. And they also can use it to remove foreign object if someone has inhaled something. Okay, we're getting our patient ready for the bronchoscopy. What should we do? Well, first of all, the patient will be NPO for 6 hours before the test is done. Often they're pre-medicated with Valium or Versed or Demerol. Dentures will be removed and any partial plates will be removed. And you want to let the patient know that they're going to experience a sore throat after the procedure. Many times for a bronchoscopy, they use conscious sedation. And we talked about that when we talked about going through the OR experience. Okay, our patient has made it through the bronchoscopy successfully. They're back with us now. What you want to do after the test is you want to make sure they sit or lie on their side. They are NPO until the gag reflex returns. Because again, remember the type of pre-op sedation that was used, and many times a topical anesthetic is used during the bronchoscopy that prevents or interferes both with the gag reflex and the swallowing reflex, and that will interfere with it several hours post-operatively. So you want to make sure the patient's NPO until the gag reflex returns. Once they have an active gag reflex, they will progress to ice chips and then to fluids. And after a bronchoscopy, what you're looking for is you want to monitor the patient for hypoxia, hypotension, tachycardia, dysrhythmias, hemoptysis or the bloody sputum, and dyspnea. Okay, let's talk about thoracentesis. Remember, a thoracentesis is aspiration of fluid and air from the pleural space. They use it to obtain specimens, to relieve lung compression, to get tissue for a biopsy, or to instill medication. The type of things you need to know about a thoracentesis, you need to know how to get the patient ready, what preparation is needed. You need to know how the procedure is performed. You need to know the care after the procedure, and you do need to know the complications or what might occur. We're getting our patient ready for the thoracentesis. Let's talk about what we need to do. Preparation, first of all, before they do a thoracentesis, what they do is an x-ray to determine where they're going to actually do the thoracentesis. Where is the fluid? Where should the needle be inserted? So before the patient gets taken to the treatment room or the procedure room, you want to make sure that the x-rays has been completed and they're in the patient's chart. What you will do once they get to the room is you will take vital signs. Sometimes they shave around the insertion site if the patient has hair there. You will position the patient with their arms on the overbed table, kind of like this, or the patient could be positioned on their side. You will tell the patient to expect a tingling sensation when the physician injects the local anesthetic, or they may feel a feeling of pressure. And with a thoracentesis, remember, they don't take more than 1,000 milliliters at any one time because of the danger of fluid shifts. Okay, patient has had the thoracentesis. After the procedure is done, they will do a chest x-ray to verify that there is no pneumothorax, because that's one of the complications that could occur after a thoracentesis. After the test, the thoracentesis is over. You will auscultate or listen for breath sounds. You will monitor vital signs. You want to check the site for drainage, and there should be a small amount of drainage, but no overt blood or hemorrhage there. And a sterile dressing is put on the site. Let's talk about a lung biopsy. Remember, a lung biopsy is where they remove lung tissue for culture and cytology. Getting the patient ready for a lung biopsy, often they're pre-medicated with a sedative or an analgesic. The position for a lung biopsy is the same position that we used for the thoracentesis, either laying on their side or their arms over an overbed table leaning forward. When a lung biopsy is performed, the patient is instructed to hold their breath mid-expiration when the needle is inserted. So they take a deep breath, and then halfway through the exhalation, they hold their breath, and that's when the physician inserts the needle. After the lung biopsy is over, what you will do is you will monitor the patient's vital signs and breath sounds. You want to monitor them for any respiratory distress. Often they will do a chest x-ray again to check for a pneumothorax because that's one of the complications of a lung biopsy. And a sterile dressing is put on the site. Again, the complications, one is pneumothorax or pulmonary hemorrhage. Another diagnostic test that is done frequently is an MRI, which is a magnetic resonance imaging. What this does is it uses magnetic fields to obtain detailed pictures of body structures. Now, patients that have pacemakers, defibrillators, implanted insulin pumps, implanted transcutaneous electrical nerve stimulation devices, or any implantable medical or implanted metal devices, it's contraindicated for them to do an MRI because of the magnetic fields and the presence of metal in the patient's body. So again, pacemakers, defibrillators, insulin pumps, TENS units, any implanted medical devices would contraindicate a patient having an MRI. Getting the patient ready for the MRI, you want to assess them for their problem with claustrophobia, although now there are some open MRIs that are used. You will remove all metal jewelry and objects from the room, and again, look around the room. When the patient is put in the room, look around the room, because once in a while someone will forget that an oxygen tank, if the patient came with that, is a metal object and can become airborne when the MRI actually takes place. And again, talk with the patient. Don't assume because they have no obvious areas on their body that look like, metal is implanted here. Ask them, do they have any metal in their body? If they have any pacemakers, talk with them about their medical history to find out if the procedure is contraindicated. And after the procedure, there's no special treatment that is needed. Let's talk about angiography. You remember that this uses dye to evaluate specific areas of the arterial system. The type of thing you need to know and is frequently tested on the exam is how to prepare a patient for an angiography, what the procedure is, what the care is during the procedure, and what complications you're looking to prevent. So let's talk about angiography. Getting the person ready, first of all, you'll remove all jewelry, and you'll tell the patient that when the dye is inserted, they may feel like nausea, they may feel flushed, they may feel suddenly very warm, and they may experience a salty taste, again, when the dye is injected. After the test, you want to assess for a hematoma at the insertion site. You want to check pulses distal to the insertion site, and you want to compare skin temperature and pulses side to side. If it was on this side, you want to compare these pulses and skin temperature to this side. Again, you want to check vital signs. Now, it's important to remember that the patient may have either an immediate or a delayed reaction to the iodine dye that is used during the procedure. And if the patient does have a reaction, the type of symptoms you will see is they will have dyspnea or difficulty breathing, they'll become nauseated and vomit, they'll sweat or become diaphoretic, they may have tachycardia, and they may have numbness of the extremity. The treatment done if the patient does have an allergic reaction or delayed reaction to the dye, they will give them epinephrine, they will use antihistamines, they will use corticosteroids. Other complications of angiography, again, that we want to prevent are vessel injury, bleeding, and CVA or stroke. After angiography, again,
other than what we talked about, comparing things and checking vital signs, no special treatment is needed. Let's talk about pulse oximetry. You remember that pulse oximetry measures oxygen saturation through the skin. What they do is they apply a probe or sensor to the finger, to the forehead, to the earlobe, or to the bridge of the nose. Now, normal pulse ox is between 95 and 100%. If your patient has a pulse ox of less than 85%, that indicates hypoxia, and that should be investigated. Now, pulse oximetry is unreliable if the patient is in cardiac arrest or shock. It's also unreliable if the patient is being given vasoconstrictor medications, because again, it alters circulation to the extremities where you're testing it, or if the patient is severely anemic. Again, the results would be unreliable. The preparation for someone for pulse oximetry, you want to clean the site using a cotton ball, soap, and water, and then clean the site with alcohol. You would then dry the skin. After they have the pulse oximetry device in place, again, it should be rotated about every 4 hours to prevent skin irritation. Let's talk about a little bit more complicated test. Another diagnostic test is cardiac catheterization. You'll remember that this is introduction of a catheter into the heart, and it is used to evaluate ventricular function and to obtain pressures in the heart chambers. The type of things that are frequently tested and you'll need to know is how to prepare the patient for a cardiac catheterization, what the procedure entails, care after the procedure, and the complications that you are looking to prevent. So let's talk about a cardiac catheterization. Remember, it's used to assess coronary artery patency, because many times they will do a cardiac catheterization to decide if a revasculation procedure, such as a CABG, which is a coronary artery bypass graft, or a percutaneous transluminal coronary angioplasty should be done. So they want to check things out ahead of time. So getting the patient ready for this, they will have an IV in place. You should check blood pressure and have an EKG tracing ongoing. You want to check any allergies to iodine, again, because a dye is used, and you don't want someone to use that if they have an allergy to it. The patient will be NPO for about 8 to 12 hours before the procedure. Permit needs to be signed because it's an invasive type of procedure. The patient should empty their bladder. You want to check the pulse, and you want to let the patient know that when the dye is injected, they may feel a sudden feeling of heat, or they may experience palpitations, or they may feel like they have to cough when the dye is injected. Let's talk about care after a cardiac catheterization. After the cardiac catheterization, again, your care is very important because it's not uncommon that complications occur after this procedure. After the procedure is over, you want to monitor vital signs every 15 minutes for 2 hours, and then every 30 minutes for an hour, and then every hour for 3 hours. So it's Q15 minutes for 2 hours, Q30 minutes for an hour, and then Q1 hour for 3 hours. So you're taking vital signs very, very frequently. You want to check pulses, you want to check sensation, you want to check for bleeding at the insertion site. And again, you want to check both the side that was used to instill or do the cardiac catheterization compared to the other side. The patient will be on bed rest about 6 to 8 hours with the insertion site extremity straight. Again, you want to make sure that that does happen. And frequently a sandbag or something is placed on the insertion site, again, to prevent hemorrhage. If this is done outpatient, and sometimes cardiac catheterizations are done outpatient, it requires about 8 hours of bed rest after the procedure is done for recovery to take place. Talk about the ears, and the first thing we're going to talk about is hearing loss. You'll remember that the ear has two functions. It's both hearing, but it also plays a very important part in balance. And remember, hearing is conducted over both air and bone. The type of things you need to know with hearing loss, you need to know the diagnostic tests. You need to know the difference between a conductive loss and sensory neural loss. You need to know how to do an ear irrigation, and you need to know how to administer eardrops. Now, for the otoscopic examination, you need to know how that's performed And with an adult, you pull the ear up and back. And for a child, you pull the ear down and back. And the way I remember the difference between the two is adults are taller, so you pull it up, and children are shorter, so you pull it down. Now, there are two tests they use to assess hearing loss. The first is the Weber test. This assesses bone conduction. You get a tuning fork in motion, you place it on the head or the forehead, and it's normal to hear the sound in both ears. Now, the Rhine test assesses air conduction. You will hold a tuning fork in motion 2 inches from the ear canal and against the mastoid bone. And usually the air conduction is longer than the bone conduction, meaning you should hear it longer here without having to put it against the bone. With hearing loss, the type of things you'll see, there may be pain, the patient may have a fever, there may be discharge from the ear, there may be altered growth and development, especially if it's a child, because so much of things for children come in auditorily. And there may be personality changes, especially with the elderly. An important thing to remember with hearing loss is, again, it's best to prevent it so you don't have to treat it. There are environmental factors such as noise, and again, you need to use ear protection if you're around heavy machinery or anything that could have sounds of such a level that would be damaging to the ear. The elderly, as you get older, there is a progressive hearing loss called presbycusis, that over time you lose some of the high-level hearing abilities. The type of symptoms other that you'll see, there's tinnitus, which is ringing in the ears. If you're in a group, and especially with an older person, you may see that they're inattentive to what's going on in the group because they can't hear it. They may turn the TV up very loud, not just to annoy you, but because they can't hear it otherwise. There may be a change in their speech. Their tone may become very flat. They may slur or drop words. The elderly also may become very withdrawn or suspicious because they hear things and they are unable to tune in and find out what it is. Or sometimes the patient will dominate the conversation because if they're talking, they don't have to worry about listening. Under hearing loss analysis, there are two types of loss. The first is conductive loss. This is a disorder in the auditory canal, the eardrum, or the ossicles. There's also a sensory neural loss. This is a disorder of the organ of corti, or the auditory nerve. Under implementation, hearing aids many times are used for patients with hearing loss. Sometimes the hearing loss is due to a buildup of earwax or the cerumen in the ear. This is very common in the elderly. And if you have an elderly person with a lot of earwax buildup, what can be done is you can instill a few drops of warmed glycerin or mineral oil or half-strength peroxide about 30 minutes before you remove the wax. And you can do this 2 to 3 times a day for several days in order to get all of the wax out. Now, one of the other treatments for hearing loss, in addition to the hearing aid or removal of the earwax, is an ear irrigation. And it's important that you know how this is performed. What you will do is you will tilt the head toward the affected side. Let's say the hearing loss is in my right ear. I will tilt my head toward that side, and then a stream of water or fluid will be directed against the canal. And then afterward, I will lay on that side to facilitate the drainage of the fluid. Other things with hearing loss you want to make sure when you're working with a patient or a client with hearing loss is that when you're speaking with them, you face them directly so they can get visual cues and may read your lips. Make sure your face is well lit. Don't obscure your mouth, talk with your hand over your mouth. You need to speak slowly and distinctly, and you need to pause frequently and make sure that the patient or the client is following with you. One of the other problems of ears is acute otitis media. What you need to know here are the symptoms, the medications, the care after surgery. You remember that acute otitis media is an acute infection of the middle ear. It is associated many times with upper respiratory tract infections, sinusitis, and allergic rhinitis. Sometimes there's a purulent exudate present in the middle ear that results in a conductive hearing loss. Let's talk about acute otitis media. The type of symptoms you'll see is usually the patient is febrile, meaning they're running fever. They have pain in the ear. They may complain of headache. They may complain of ear noises or tinnitus. If it's a child, they may roll their head around and cry and kind of tug on their ears because they hurt. Again, with children and infants, you have to rely on the nonverbal signals to know that there's a problem here. Let's talk about the implementation for acute otitis media. They will use medications, and the medications are antibiotics, antihistamines, and nasal decongestants. They may do a laryngotomy, and remember this is an incision into the tympanic membrane, and it is used to relieve pressure and to drain secretions. They will do a culture insensitivity on the fluid that's removed to make sure that the antibiotic, they're giving the right antibiotic for the problem that the person has, and usually the laryngotomy heals within 24 to 72 hours. They may, at the time they do the laryngotomy, actually place in ear tubes or ventilation tubes. Usually these are retained about 6 to 8 months, and what they do is they kind of take the place of the eustachian tubes to equalize the pressure both outside and inside. And a lot of children have these to help them with their frequent bouts of acute otitis media. And after this type of surgery, you will position the patient on the side of the affected ear after the tubes are inserted.
Okay, let's talk about some treatment modalities now in the psychiatric area. The first is called milieu therapy. And in milieu therapy, the client's environment is manipulated to help the client return to the community. So the focus is on living, learning, and working. It provides a therapeutic environment for the client. The client plans social group or group activities. This can happen in an open ward on a psychiatric unit, or perhaps it can also happen in a halfway house. There might be a token program where clients are given or rewarded with tokens, for behavior, and then they're able to turn these token programs in for some sort of a reward. Also, clients self-medicating is also part of the milieu therapy. The next treatment modality is group therapy. And group therapy helps clients work through issues in a group. What occurs in group therapy is the individual feels respected and accepted by the group. Group members monitor each other's reactions and provide feedback in a non-threatening way. Hopefully group members feel secure when they know that they're not the only ones that are experiencing a particular problem. Also, by listening to other people express themselves, maybe in the group, maybe the client will have a better understanding of themselves and what they're feeling or experiencing. Also, by listening to people talk, one can gain insight into their own behaviors or symptoms. Also, in a group, members learn to assert themselves. Now, in group therapy, relationships with others are recreated among the group. There is always a leader, so they meet regularly with the leader, and through this group exploration, they learn how to cope, learn new ways to cope with stress, and develop insights into their own behaviors. Another treatment modality is family therapy. Now, the focus of family therapy is changing relationships through changing the interactions among family members or between couples. Many times when you have a family situation where perhaps you have an adolescent who's acting out, you have one of the adult members of the family with a substance abuse problem, this person becomes the focus of the family interactions, and they become the sick individual. And, it's kind of, I'm okay, and this is the person that's sick. So in family therapy, it's the family that becomes the patient, not the individual. Many times family members lack a sense of I, and so it's working on that. So you treat the whole family. You're working toward each family member developing their own identity, and then looking at the way they function with each other and how can they function in a more healthy way. Many times, all of the problems of the family is blamed on the sick member, but that's really not the issue. The next treatment modality is activity therapy. And in activity therapy, which can be physical activity, arts, or crafts, your group members work together on tasks. The focus is the interaction between the group members. Activity therapy promotes socialization and also increases self-esteem. The next treatment therapy is play therapy. Play is the language of children. You know, when you're dealing with kids, many times they don't have the vocabulary to necessarily express what they've experienced or what they're feeling, but they act it out through their play. So they express their feelings in play. As the nurse in play therapy, we're going to look at the toys the child chooses, their colors, because, you know, when they color a picture, are they scribbling an angry red, or do they have a nice pale blue sky there? Because this gives us some insight into what the child is feeling. During play therapy, this facilitates interaction between adults and the children and will help the children or allow the children an opportunity to act out their conflicts, work through feelings, and help the child develop more adaptive ways to cope. Now, it's important that when you're engaged in play therapy that the nurse recognize the child's feelings and reflect these back. The next treatment modality, and the last one, is behavior modification. Now, in behavior modification, it is believed that behavioral therapy is based on learning theory, that behavioral responses are learned and can be modified. And on this, you think of Pavlov's dogs. So with behavior modification, there's operant conditioning, and that is the use of rewards to reinforce positive behavior. For example, with young children who perhaps have conduct disorders, the family may be encouraged to have a good behavior chart. So every time the child behaves appropriately, you know, you tell them to put their shoes away and they do it, you reward the good behavior by giving them a star. And after their good behavior chart is filled, then they have the opportunity to go get a reward. So this is positive reinforcement. So you ignore the negative behavior and you reinforce the positive. Sometimes we look at that and we say, well, you know, isn't that wrong, because then people are just doing things to get stuff, to get the reward. But if you think about it, that's what we do as adults. I mean, we work hard because we hope that we get a raise next year. We work hard, you know, because we hope for a bonus. So same principle. Now, another part of behavior modification is desensitization, or systematic desensitization. And this is where the client is exposed to a threatening object for short periods of time, and then the time of the exposure is increased until the client's fear or anxiety goes away. Now, what you need to know about anxiety is you need to know the assessment and implementation for anxiety. You need to understand examples of ego defense mechanisms, and you also need to know the assessment and implementation for phobias. Okay, what is anxiety? Anxiety is a feeling of dread or fear in absence of an external threat, or a disproportionate response to the nature of the threat. Now, anxiety affects all of our body systems. It causes palpitations and it causes us to perspire. Maybe our hands and feet just feel like blocks of ice. May cause nausea or indigestion and heartburn. Maybe we have increased muscular tension, and along with the musculoskeletal system, that causes the unsteady voice, or we may just feel a generalized fatigue. We may have poor comprehension. A client who is anxious may have difficulty following directions. They may have poor concentration or impaired problem solving. They also may be feeling just absolutely helpless. And what you will find is your client who is anxious may revert to more primitive coping behaviors such as shouting, arguing, hitting, kicking, or crying. Now, it's very important that you be able to assess the level of anxiety that your client may be experiencing. Now, if a client has mild anxiety, this is just that nervousness that we feel. We're alert and we're uneasy. I am willing to bet, because all of you are preparing for your NCLEX RN exam, you are feeling mildly anxious now because you want to make sure that you pass your test. So mild anxiety is a positive thing because it helps mobilize us to figure out what we need to do in order to be successful on the NCLEX RN exam. The next level is moderate anxiety. In this, it's the heart pounding, the skin feels cold, and this is when clients begin having difficulty comprehending. Now, if a client is having mild anxiety, they may be experienced over long periods of time, the chronic mild anxiety. They may develop anxiety disorders such as panic disorder, phobic disorders, generalized anxiety disorder, or obsessive compulsive disorder. Now, if you have a client who's experiencing moderate to severe anxiety, they're going to be having hallucinations and delusions. So, for example, if somebody has experienced moderate to severe anxiety over a long period of time, they might develop one of the somatoform disorders, either conversion, hysteria, or they may become a hypochondriac. They may develop dissociative disorders such as amnesia or depersonalization, or they may have one of the personality disorders. Now, the highest level of anxiety is a panic attack. And in a panic attack, the client literally feels like they're losing their mind or they're having a heart attack. They have palpitations, they have difficulty breathing. Now, if you have a client who's says they've had panic attacks, it's not that they feel mild anxiety, then moderate anxiety, then severe, and all of a sudden it hits panic. They go from feeling fine to just simply experiencing a panic attack. Now, how does the body deal with anxiety, or how does not the body, but the mind deal with anxiety? It does this through ego defense mechanisms. So let's talk about the ego defense mechanisms. Now, these are unconscious methods of managing anxiety by keeping it away from our awareness. And what you have to be aware of is the client doesn't choose a defense mechanism. You know, for me personally, I don't have denial. I wish I did, and if I could develop a denial button, I would do it. It's just something that's a part of each person's makeup. Now, as with a lot of the behaviors in mental health, these defense mechanisms can be adaptive or they can be maladaptive. So let's look at some ego defense mechanisms. The first is denial. This is the failure to acknowledge intolerable thoughts. So, for example, the alcoholic who says drinking isn't a problem in my life, or the person who's dying, you know, who the physician has said, you know, I really believe you have, you know, about 3 months, and this person says, well, no, you know, 18 months from now, I'm taking my family to Europe. Those are examples of denial. The second defense mechanism listed here is displacement. And this is redirecting feelings to a more acceptable subject. And this is a neurotic or an intermediate defense mechanism. An example of this would be you're mad at your nursing instructor, she didn't like your care plan, and you go back to your apartment and you yell at your roommate because there's dirty dishes in the sink. So that would be an example of displacement. Another ego defense mechanism is projection, and that's attributing your own feelings to somebody else. Now, this is an immature defense mechanism, and it's the basis for blaming or scapegoating. You know, for example, you know, maybe you get a bad evaluation, so you complain about, you know, what an idiot your nursing instructor is. So that's projection. Another defense mechanism is undoing. This is the attempt to erase an act, thought, or feeling. And again, this is a neurotic or an intermediate defense mechanism. An example of this would be a spouse who is having an affair with a person, and they turn around and buy a very expensive gift for their spouse while they're engaged in the affair. Another ego defense mechanism is compensation, and this is an attempt to overcome real or imagined shortcomings. For example, the child who had asthma and was in the hospital a lot, as an adolescent becomes the star athlete. Another ego defense mechanism is symbolism, and this is less threatening objects are used to represent another. For example, dreams and phobias are examples of symbolism. Then we have substitution, and this is replacing an unacceptable or unattainable object with one that is acceptable or attainable. For example, maybe a person is engaged, and the person they're engaged to breaks up with them and marries somebody else. Well, the person who got dumped marries somebody that looks like the former fiance. So that's an example of substitution. Another ego defense mechanism is introjection, and that is the symbolic taking into oneself the characteristics of others. So, for example, if I'm angry with you, I blame myself for what's going on. Other ego defense mechanisms include repression, and this is a neurotic or intermediate defense, and this is unacceptable thoughts being kept from awareness. You know, for example, we just forget all about a painful experience. I've been married before, and somebody's talking to me about my former spouse, and I can't remember the person's name. That would be an example of repression. Reaction formation is expressing the attitude opposite of unconscious wish or fear. So this is basically an overcompensation or a neurotic or intermediate defense mechanism. So this is the person who's just having a lot of challenges with their elderly mother, and they're, angry and unhappy about it, but they turn around and they become a volunteer in an adult daycare facility dealing with older adults. Another ego defense mechanism is sublimation, and this is substituting a socially acceptable activity for an unacceptable impulse. And this is a mature ego defense mechanism. Many times these impulses are sexual or aggressive in nature. So, for example, you have a young man who's really angry and, really wants to act out aggression, so they choose to play rough contact sports. The use of sublimation is always constructive. The next ego defense mechanism is regression, and this is returning to an earlier developmental phase. For example, maybe there's a 4-year-old child in the family, and mama brings home the second child, a brand new baby, and all of a sudden this 4-year-old who's been taking care of themselves just fine starts having temper tantrums, maybe starts wetting the bed at night, or begins baby talking. Disassociation is detachment of a painful emotional conflict from the consciousness. And this is an immature defense. This is amnesia. Maybe something happened earlier in the day that is very hurtful to you, and somebody brings it up later in the day, and you're like, well, I don't remember it. What are you talking about? Suppression is another ego defense mechanism. And it's consciously putting the thought out of awareness, and this is a mature defense. What I always think about with this is I love the movie Gone with the Wind, and there's a line in there where Scarlett O'Hara says, I'm not going to think about that today, I'll think about that tomorrow. That's an example of suppression. Or the student nurse who says, yes, I need to look for a job, but I'm not dealing with that until after I pass my NCLEX RN examination. So these are examples of ego defense mechanisms, and remember, they're a way of dealing with anxiety and the psychic pain. Now let's talk about how are we going to care for a client who's experiencing anxiety. The very first thing you're going to do is assess their level of anxiety. It's very important that you look at their body language, their speech patterns, facial expressions, and what defense mechanisms are they using to determine their level of anxiety. When anxiety is high, it's very important as the nurse that you decrease the patient's environmental stimuli. This is going to be your first action. So you're going to make your orientation or your instructions very brief. You're going to write everything down so this person can read it later, because remember, they're having difficulty comprehending. If you have a client that's being overstimulated by their surroundings, you're going to put them in a more private place to prevent this overstimulation. And very important, if you've got a client with high anxiety, don't be offering them a bunch of choices, because they're having difficulty comprehending. They'll have difficulty making a decision, which will simply make them even more anxious. You're also going to assist the client to cope. You're going to do this by staying with your patient. Now, those of you all who have been in class already know that we're always saying to you, stay with your patient. And that's a very important thing to do on the NCLEX RN exam, and it's usually the right answer. You're going to stay with the patient. But in reality, in practice, you're also not going to abandon your patient. You're going to stay with them. It's very important that you acknowledge the client's anxious behavior and help them clarify their thoughts and feelings. In the long term, to deal with anxiety, it's important that you encourage the client to exercise regularly, because it's a great way to reduce stress and anxiety. Perhaps get engaged in a hobby, fishing or collecting of some sort, or that they talk to other people, friends or family, when they're anxious, to help reduce the anxiety. It's also very important when you're dealing with your client who's anxious that you help them recognize their strengths, and deal with their weaknesses. Also, you may administer anti-anxiety medication. Now, these are found in the chapter in your course book under pharmacological and parenteral therapies, and make sure and review the anti-anxiety medications. Now, when you're dealing with your client, it's important that you maintain an accepting and helpful attitude. Use unhurried speech, because if you start rushing them along, they're going to be even more anxious. It's important that you acknowledge their distress and their concerns, and that you encourage them to clarify their feelings. Now, it's important that you acknowledge their defense mechanisms, but don't take them away. Just simply try and provide reality. Because remember the value of the defense mechanism. It's the client's way of trying to make the anxiety tolerable to themselves. But you do want to provide reality. Now, other things that you're going to need to know for the NCLEX exam include how to assist with breastfeeding and also how to perform the Kegels exercises. All right, let's talk about breast care in the antepartum period. First of all, you're going to teach the mother to avoid the use of soap on her nipples. This is important both antepartally and postpartum if the woman is breastfeeding. During the pregnancy, encourage the woman to expose her breast to air and sun, the nipples, because this will help toughen them. And also the client should investigate any redness or swelling. Now, when you bring the baby to the mom for the first time and you help the mother to initiate the breastfeeding experience, first of all, it's important that the mother feel relaxed. And there's several different positions she can be in. She can be sitting in a semi-Fowler's position or Fowler's position holding the baby. Some women like to initiate the breastfeeding experience by lying on their side and supporting the baby on the bed. It's important that you position the nipple in the infant's mouth so it covers most of the areola, and that you teach the mother that when she goes to release the infant's mouth from the nipple, that she insert her finger to break off the section. She just doesn't want to say to the baby, okay, time for the other side, and pull the baby off. The mother should offer both breasts at each feeding, and she should alternate when she starts. So she's going to start by breastfeeding for 5 minutes. If she starts on the left side for 5 minutes, then she goes to the right side for 5 minutes. At the next feeding, she starts with the right side and goes to the left side. This way you encourage the formation of stimulate the breast to form to make the breast milk. And like I said, remember to break the section by inserting a finger. Now, engorgement is a problem for both breastfeeding and non-breastfeeding women. So I want to talk first about the women who are breastfeeding. Engorgement occurs when just all of a sudden the breasts are completely filled with milk. So what you need to do is encourage the woman to nurse every 30 minutes to 3 hours. Now, sometimes the breasts are so hard that the baby can't latch on. So in that case, you would want to stimulate the breast so the letdown reflex will happen. She'll leak some breast milk, which will soften the breast just enough so the baby can then feed. It's important that the mother completely empty each breast with each feeding. How does she know the breast is empty? Because the baby will continue to suck. Well, when the baby continues to suck but there's no swallowing occurring, then that's when the breast is empty, so then she needs to go to the other side. Also, warm showers and compresses will also help relieve the engorgement, and alternating feeding or alternate the breast for each feeding. Now, what happens with the mothers who's bottle feeding? Because she may likely get engorged too. Well, if we say to her, empty your breasts every 30 minutes, go stand in a warm shower and just let this milk leak out, what's going to happen? Milk's going to come back again. So for these clients, we don't want them to do anything that would cause the milk to leak out. So they should wear a bra. They should not stand in the shower, even though it's going to make them feel a whole lot better for a short period of time until the milk comes back. Offer them mild analgesics. They should wear a good supportive bra 24 hours a day. And for discomfort, they will use ice packs. All right, the Kegels exercises, which we talked about before, the client contracts the pubococcygeal muscles that stop the flow of urine. So it's important, and if a woman's not sure, how to do this, just tell her to, when she's going to the bathroom, start her stream of urine, then try to stop it by contracting the muscles. That's the Kegels exercise. So she's going to tighten the muscle, hold for the count of 3, and then relax it. And this should be practiced 10 times TID. So this will decrease the urinary incontinence. Also encourage the client to avoid diuretics such as caffeine. Now, we've been talking about parenting all the way through, and I think this is one of the primary functions of the nurse. It's very, very important that we begin instructing our parents from the moment the baby's born about what to expect. Remember, we talked about abuse being a problem, and if people know what to expect, then they're better able to judge their infant and their development at that stage. It's very important that we provide anticipatory guidance. We don't wait till the parents come to us to start asking the questions, and we've gone through in a rather detailed way the growth and development of infants. So you're going to be explaining this to your parents. Also educate them regarding routine health care, bringing the babies back for regular checkups so they can be evaluated as far as their height and weight and receiving their immunizations. I also think it's very important that we observe our parents' response to new babies. Having a new baby is such an exciting time, but it's a stressful time too. And you want to make sure that your mother and your dad are able to handle the stress of the new baby, and many times educating them about what to expect, what's normal, and things that they can do to facilitate normal will give them the comfort they need to decrease their stress level. Let's talk about now childbearing maternal complications. Everything we've talked about has been what's normal. So now we're going to talk about some complications that you may encounter on the NCLEX exam. The first is dealing with a spontaneous abortion. Now, spontaneous abortion, the symptoms of this is persistent bleeding with cramp-like pain. Clients will either have a negative pregnancy test or a weekly positive pregnancy test. As far as the implementation goes for these clients, we're going to be monitoring their vital signs very carefully. We're going to be checking for bleeding and pain. We're going to save all tissue that the client might pass. If you have a client who's Rh negative, they're going to receive RhoGAM. And it's also vitally important that we provide emotional support to these clients because they've lost a pregnancy. Let's talk about the types of spontaneous abortion. The first is a threatened abortion. Now, in a threatened abortion, the cervix stays closed, but there is vaginal bleeding and cramping. So what are you going to do for this client? You're going to encourage them to rest, stay off their feet for 24 to 48 hours, no sexual intercourse for 2 weeks after the bleeding stops. And it's important for the client to monitor clots, tissue, or any foul odor. Inevitable abortion sounds like it is. The cervix is dilated, so it is inevitable that the client is going to pass the products of conception. These clients have persistent symptoms of hemorrhage and moderate to severe cramping, and there is cervical effacement and dilatation. We're going to continue to monitor for hemorrhage, and that will be accomplished by saving and also counting pads. It's also important that the client save any tissue that may be passed, and again, we're going to support them because they're losing a pregnancy. An incomplete abortion is where part of the products of conception have been passed, but not all of them. So this client has persistent bleeding and persistent cramping. We're going to give this client IV oxytocin, which will cause the uterus to contract. Any retained products of conception will be removed through a suction evacuation, and again, support the family. A complete abortion is when all of the products of conception are expelled. A missed abortion is a fetus that dies in utero but is not expelled. Cervix stays closed. If the products of conception are retained longer than 6 weeks, then they will do a D&C with an evacuation, because one of the complications of a missed abortion is DIC, or disseminated intravascular coagulation. The person who is considered a habitual aborter has spontaneous abortions with 3 or more pregnancies. And this may be due to an incompetent cervix. So for these clients, they will do the purse string suture, or the cerclage of the cervix to keep the cervix closed. Other complications that you need to know for the NCLEX exam are symptoms and care for an ectopic pregnancy, how to identify and care for the client with a diagnosis of pregnancy-induced hypertension, the differences in symptoms and care for placenta previa and an abruptio placenta. So let's look first at the ectopic pregnancy. Now, you know that an ectopic pregnancy is a pregnancy that's implanted outside of the uterus, and usually the fallopian tubes is the most common place. So these clients have pain due to the fact that the pregnancy has grown till it gets to a point where the tube ruptures. This is a potentially life-threatening situation for the mother due to hemorrhage. Causes of ectopic pregnancy include pelvic inflammatory disease, prior tubal surgeries, or congenital anomalies in the fallopian tubes. These clients are going to present usually to the emergency room with unilateral lower quadrant pain that occurs after 4 to 6 weeks of pregnancy. Since they're bleeding into the abdomen, you will palpate a rigid, tender abdomen. Hematocrit may be low. They'll have a low HCG level in both the urine and the blood. And the bleeding increases from just a gradual oozing to a frank hemorrhage. What you're going to do for these clients is, first and foremost, you're going to monitor for shock because they are bleeding internally. You're going to prepare the client for surgery because they're going to surgically remove the fallopian tube and probably the ovary that is on that side. You're going to administer RhoGAM if the woman is Rh negative. And again, very important to provide for support, because not only has this woman lost the pregnancy, but she also has lost a tube and an ovary, so she's going to have concerns about future fertility, about being able to conceive again. Hey, let's talk about pregnancy-induced hypertension. First, let's talk about who is at increased risk for pregnancy-induced hypertension. And you know, this is hypertension that occurs after the 20 weeks of gestation, most commonly seen in the last 10 weeks. A woman who has a large fetus is older than 35 years or younger than 17, a prima gravida, anybody who may have multiple fetuses or a hydatiform mole, maybe somebody who is undernourished. Client has a history of diabetes, renal disease, and vascular disease, or a family history of hypertension. The pregnancy-induced hypertension is divided into categories. The first is mild preeclampsia. This begins after the 20th week of gestation. You're going to see the blood pressure of 140/90 if the client has no baseline blood pressure, or an increase of 30 millimeters systolically and 15 millimeters diastolically. The client will have 2+ and 3+ proteinuria, and there will be slight generalized edema. Now, for your client who has mild preeclampsia, they are going to be cared for at home. They will be placed on bed rest in the left lateral position. It's important that they're given a well-balanced diet. Want to encourage the proteins because they may be losing protein in their urine. We don't have to reduce the client's sodium intake, but we are going to tell them to lay off the pretzels and the real salty foods. Client is going to have to weigh herself daily because this is the way it's going to be determined if she's retaining more fluid. And certainly diversional activities are important because it's really boring to be pregnant and have to stay in bed all the time. With severe preeclampsia, you're going to see the same kinds of symptoms, only they're just more severe. A blood pressure of 150 or 160/100 to 110 millimeters of mercury, 4+ proteinuria, headache, and epigastric pain. Epigastric pain is a danger sign or warning sign that the client is getting ready to have convulsions. Care for the severe preeclamptic, usually they're treated in the hospital. You're going to put them on bed rest. Monitoring vital signs frequently is absolutely vital to monitor their blood pressure, but it's also very important to monitor the baby's fetal heart tone because this indicates the oxygenation that the baby's getting. Monitor I&O. This client will be placed on seizure precautions, and they may also receive medications such as magnesium sulfate, which prevents the seizure activity, and this will be given through a magnesium drip, and you're always going to be evaluating deep tendon reflexes in their respirations because it can depress both. They may be given Valium, which sedates the mom, and as well as sedating mom sedates the baby, as well as antihypertensives such as apresoline or Procardia. Now, if you have a client who is eclamptic, that means they had a seizure. They're having a seizure. This is an obstetrical emergency. So symptoms really is the coma, or that's the main difference between severe preeclampsia and eclampsia. This client is going to have an IV going with a large bore needle. You're going to be monitoring fluid balance. Minimize any environmental stimuli to decrease the seizures. Have airway and oxygen ready. You're going to administer medications, the same medications that we've just talked about. You're also going to prepare for possible delivery. It's the only cure for PIH. The baby has to be born. It's the only way you're going to get rid of it. Monitor for seizures and fetal status. Make sure and monitor the mother for 24 to 48 hours after the delivery for seizure activity because they can continue to seize. Hello and welcome. My name is Barbara Irwin. I'm the Director of Curriculum for Kaplan Nursing, and I welcome you to this talk about health promotion and maintenance. Health promotion and maintenance is about 6 to 12% of the test questions that you will be seeing on the NCLEX exam. Health promotion covers a rather broad area. It includes growth and development, and I do want to emphasize that it's growth and development. Toy, stages of play are very, very important to the NCLEX exam. Also, we're going to be talking about obstetrical nursing, both normal and the complications. We're also going to be talking about the conditions that are associated with reproduction, and we're going to end with some wellness issues, prevention and early detection of disease. Now, remember, with the growth and development, here in the United States, the focus is on the prevention of illness and the maintenance of health. And this, I think, is most evident in this whole unit about growth and development. It's very important in growth and development that you master what is expected of each age group of your children, because we're going to anticipate problems and then offer guidance to our families to facilitate wellness. Remember that the care is family-centered, because we recognize that the family is the one constant in the child's life. What we hope to do with the knowledge of telling the families what's normal and about their children's growth and development is we're enabling and empowering these families to promote the growth and development of the development of their children. And remember, our goal is wellness. Let's begin. Now, we're going to be talking about things that you need to know for the NCLEX exam. So the need to knows are, these are topics that are likely to be tested on the exam. It's very important that you know the stages of play. It's important that you know Erickson's developmental tasks. Also, the normal outcomes or behaviors for each age group. We're going to talk about the sequence of adding solid foods to a toddler's or to an infant's diet, and also appropriate toys for each age group. Before we get started, I just want to just remind you all, especially those of you all that have children, it's easy for you when we talk about an 8-month-old for you to visualize where your child was at 8 months. And I think that's really good that you're able to visualize that. But the most important thing you need to do is don't use your children as benchmarks, because we want to look at the textbooks. And the textbooks, for example, say children are walking by 15 months. Well, if your child walked at, 10 months, don't say, well, by 15 months a child should be walking, because the textbooks say that is the age that they should be walking. Also, try not to memorize individual pieces of information. What we want to do is tie all this together so it will be easier for you. Let's begin by talking about the stages of play. Infants, which are 0 to 1 year of age or to 12 months, they're into exploratory play. They use their mouths a lot. They like holding toys, but because of their development, they can't do a lot more than that. From the ages of 1 to 7, children really play by imitation. They're into using toys as adult tools. So, for example, this is the age where the children will have the kitchens, or they'll have dad's play belt, or whatever else, those imitation toys. From 8 to 12 years, the children are into games and hobbies. So they will be playing the organized sports or board games. Okay, let's look at infancy just a little bit more. With infants, they're engaged in solitary play, or they play alone. The play is very one-sided. Children at this age, the 0 to 12 months, they really enjoy playing with their body parts. This is when they suck on their fingers, they suck on their toes, because not only are their body parts objects of play, but also objects of pleasure. From birth to 3 months, a baby is rather passive. So their main play is through smiling and squealing. From 3 to 6 months of age, the children play with rattles or soft stuffed toys. From 6 to 12 months, this is when the children begin their imitation. So you'll see the children playing peekaboo games or pat-a-cake with their parents. Now, while it is solitary play, the infants do like to interact with others, usually the parents. So the infants choose who they want to play with. They just won't interact with anybody. When you deal with your toddlers, you're dealing with parallel play. Toddlers play alongside of others, but not necessarily with them. They use all of their senses to play. They are running, they are feeling things. Talking for a toddler is also a form of play. Now, when you go to your preschoolers, you're dealing with an associative play. Now, in associative play, you have children in groups who are playing with similar or identical objects, but they're not necessarily playing together. So in associative play, what really is the distinguishing characteristic is it lacks the rigid rules or organization that play for a school-age child will. Also, it's imitative play. The children at this age love playing dress-up. They love imitating what their parents are doing, you know, talking on the telephone, playing with the tool belts or the kitchen or the housekeeping toys. When you hit school-aged children, they are, the characteristic of their play is cooperative play. This is where team play really begins. School-aged children can get together as a group. They can not only establish the rules of their play, they can agree on them, but they also can uniformly conform to the play. So in school-age play, the children do expect conformity. Now, there's several screening tests that might be asked about on the NCLEX exam, and the main one is the Denver Developmental Screening Test, the DDST, or the Denver 2. Now, this measures a child's development in 4 areas, and by the children being assessed by the Denver Developmental Screening Test, we're able to, 1, reassure parents that their children are developing at a normal rate, and 2, we're also trying to identify problems early so we can help rectify these problems. Now, the Denver Developmental Screening Test screens the children in 4 areas: in personal social development, fine motor development, language development, and gross motor development. Now, the Denver Developmental Screening Test is administered by somebody who is trained, so as a nurse you won't necessarily be the one who will be administering the test, but you certainly will be interpreting the results. Another topic that's so important to the NCLEX exam is Erickson's developmental tasks. Now, Erikson is much more important to the test than Freud or Piaget. They're all dealing with theories of development. Erickson's theory is of personality development is that it emphasizes the development of a healthy personality, and it identifies favorable and unfavorable outcomes. The first age group that you're going to be dealing with is birth to 18 months, and this is infancy. These children are working on trust versus mistrust. Now, you certainly could understand why an infant would be developing trust at this age, because this is where they learn that if they're hungry, somebody will feed them. If they're cold, somebody will make them warm, that somebody's going to interact with them. So consistent, loving care by a mothering person is essential in order for the children to develop trust. Now, the positive outcome is that the children trust not only themselves, but they trust the world around them. The negative outcome is the children become withdrawn and isolated because their basic needs have not been met. The second stage of Erickson's developmental task is for ages 18 months to 3 years, or the toddler. Now, the task that toddlers are working on is autonomy versus shame and doubt. It's during this age, between 18 months and 3 years, that a toddler learns that they can control themselves and they can control the environment around them. Now, it's very important that children want to do things for themselves at this age, and we should certainly encourage this because, again, it's the control that they're trying to master. The positive outcome is that the children learn to exercise self-control. The negative outcome is the shame and the doubt, so the children become negative and defiant. If children feel that they've been made to feel small or self-conscious, they're not going to be able to exercise the control when they're able to do so. The next stage of Erikson's developmental task is the preschooler, and this is ages 3 to 6 years. These children are working on the developmental task of initiative versus guilt. Now, children at this age explore the world. I mean, they're really all about figuring out what's going on. And it's at this age that children develop a conscience. Prior to age 3, if a child wants to grab a toy, they'll grab a toy. And there's not that little voice saying to them, but somebody else is playing with it, and you really shouldn't be grabbing that toy. So it's at this age children develop conscience. One of the big things they have to learn is how do they pursue their own initiative without trampling on the rights of others. It's at this age that the children adjust to going to school also. Now, your positive outcome is the children learn limits. So they learn not only limits, but direction and purpose. The negative outcome is the children become fearful and pessimistic. They're afraid to try new things because of what might happen. The next stage of Erikson's developmental task is the school-age child, or the 6 to 12-year-old. And the task they are working on is industry versus inferiority. My image of a school-age child really is twofold. One, it's the playing the games. They start games and they like to finish them. The second is that of a Boy Scout. You know, they enjoy sitting down and saying, I'm going to earn this badge, and these are the activities I need to do in order to accomplish this task. So school-age children are workers and they are producers. They achieve things and carry it out to completion, whereas your preschooler starts things, but they can't always finish them. Now, the positive outcome is the sense of confidence that they can begin tasks and they can be successful achieving their tasks. The negative outcome is that the children feel inadequacy. They feel self-doubt, inferiority. The next stage is adolescence, and this is from age 12 to 20. What a broad range of ages when you think about a 12-year-old and a 20-year-old. But what these children are working on is identity versus role diffusion. This is such a time, the changes in a child at this point are so dramatic because their bodies are changing. They're going from their childhood body to their adult body. Also, their roles are changing, and what an adolescent is really working on is trying to figure out how they fit in. How do they fit in with their peer groups? How do they fit in with their families as they gain more independence and more autonomy? And how do they fit into society as a whole? The positive outcome of adolescence is a coherent sense of self. They also, at this age, learn devotion and fidelity to others. The negative outcome is the role diffusion. The adolescent doesn't know how or where they fit in if they don't master this task. So these are the people that are just follow the leader to wherever, and usually it's not necessarily to good ends. Okay, the next phase is for the young adult, and this is age 20 to 45. The young adult is working on intimacy versus isolation. It's during this time period that the young adult forms intense and lasting relationships with others. It's at this age that the young adult masters commitment, not only towards somebody else in a relationship, but also toward a career and toward society as a whole. At this age, what one really has to learn is how they can share their own identity with someone else in this intimate relationship without feeling a loss of a personal identity. The positive outcome is love. People are able to form intimate relationships. The negative outcome when they avoid intimacy is emotional isolation. The next stage is 45 to 65 years old, and this is middle adulthood. The task that people are working on is generativity versus stagnation. Now, at this age, this is when somebody's at their peak productive years. So they've mastered their own goals. Hopefully the intimate relationships have been formed. Hopefully they're doing well in their positions. So at this age with generativity, one is as concerned about providing for others around them as for providing for themselves. It's very important that when somebody masters generativity, how you will know it is you will see them guiding the next generation, not only at home and work, but in the community also. The positive outcome, these people are creative and productive, and they care. Caring really is the positive outcome. They care for others as much as they care for themselves. The negative outcome is you have an individual who's self-centered. And many times when you deal with middle-aged people, that you see them going through, this second adolescence, if you will. They revert to younger ages, dressing, maybe a woman dresses like a teenager, a man hooks up with a younger woman. For many of these people, really, this indicates that they haven't developed this task of caring because they regress to adolescent behavior. When you get to the last developmental task, this is 65 years to late adulthood or to death. And the task that these individuals are working on is integrity versus despair. Integrity means that a person looks back over their lives and they're content with the outcome of their lives. Another way to look at it is no regrets. They don't want to go back and they don't want to do life over again. The positive outcome, if they see life as meaningful, is wisdom, and they want to share this wisdom with others. The negative outcome is that their life lacked meaning and that they really want to go back and redo life. Many times with people who don't master this task, they end up isolated and alone.